Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Hello everyone. This is Hussam Ziada, Assistant Professor of Ophthalmology at Al-Azhar University, Cairo, Egypt. And the lecture today is about the diabetic retinopathy. So first, I will talk briefly about the diabetes mellitus, which is a metabolic disease that causes high blood sugar. The hormone insulin moves sugar from the blood into your cells to be stored or to be used for energy. With diabetes, your body either does not make enough insulin or can't effectively use the insulin it does make. High glucose level damages the inner linings of both big and small arteries. The arteries respond by layering on plaque, a substance that fills the arteries so that the oxygen-rich blood has a hard time getting through to the eyes, kidneys, legs, and feet. This condition is called atherosclerosis or hardening of the arteries. Anyone can have the hardening of the arteries, but according to the Society of the Vascular Surgery, it gets more common in older people. It can cause heart attacks, strokes, and prevent oxygen from getting to the legs, feet, as well as the eye compartments. If the peripheral arterial disease is not treated properly, it can lead to peripheral gangrene and amputation. So the same for the eyes. If not treated properly, it may lead to chronic ischemia and loss of vision because of the loss of the tissue viability and loss of function. What's the diabetic retinopathy? It's the disease of the retina caused by microangiopathy due to long-term effect of diabetes, leading to progressive damage of the retina and finally blindness. Most common cause of severe bilateral visual loss in working age group in both developed and developing countries. Risk factors for the diabetic retinopathy, the age and diagnosis of diabetes, also the duration of diabetes. So the age is very crucial because the type 1 is more aggressive than the type 2, especially if the patient with a type 2 had the diabetes in a very old age. So the effect is much less than the young age, especially the childhood. The duration of diabetes, also its long-term effects, so the chronicity of the disease is considerable. So the longer the duration, the more prone to the effects of the diabetic retinopathy. Poor metabolic control. The good control proved by the evidence-based medicine studies and groups that the proper and good control of the blood sugar decreases the risk by about 30% than the bad control groups. So the poor metabolic control is a very important risk factor for developing diabetic retinopathy. Pregnancy, because of the hormonal change and also the metabolic changes in the body. And as you know, there is a special type of diabetes. It's called the pregnancy-induced diabetes because of the hormonal disturbance inside the body. Also the hypertension because of the compound or the doubled effect of the hypertension of the blood vessels and developing the atherosclerosis. Nephropathy is the same with risk factor because the nephropathy may be caused by the diabetic blood vessel changes, which affects the fine and tiny blood vessels in the kidney, which will be alarming sign for the eye because the blood vessels of the eye are very similar to that of the kidney capillary circulation. So nephropathy is the risk factor and the reverse. Others, like smoking, obesity, hyperlipidemia, and anemia. Pathophysiology. The diabetic retinopathy is a microangiopathy, primarily affecting the precapillary arterioles, capillaries, venules, and postcapillary venules. The minor and the micro part, the very small and tiny part of the circulation everywhere. So the basic component of the damaging process are the microvascular occlusion and microvascular leakage. So the pathophysiology of the diabetic retinopathy everywhere, especially in the eye, is the microvasculature occlusion and then leakage with the expansion and the other changes which will be shown in the coming slides. As you see in this figure, the microvascular leakage and occlusion in this network between the arterioles, capillaries, and venules. There is occlusion, which leads to retention of the fluids, plasma, and blood cells inside this blood vessel, which is already narrowed by the atherosclerosis. So this leads to expansion and ballooning, forming the microaneurysms, and then leakage of the plasma and leakage of the blood, leading to the hemorrhages and leakages or edema. Capillary changes are in the form of degeneration and loss of the pericytes, and as you know, the pericytes are the cells present in the wall of the blood vessels, or the capillaries, which is responsible for the regulation of the fluid exchange between the inside and the outside of the capillaries. So damage and loss of the pericytes leads to loss of the control, and so the exudation occurs, and leakage and edema occurs in the retinal layers and tissues. Thickening of the basement membrane. Also the same leads to narrowing and changes in the nature and the lumen and the behavior of the capillaries. Damage and the proliferation of the endothelial cells lead to the same sequelae. Also, there are a lot of the hematological changes, like the deformation of the RPCs and Rolux formation, increased plasma viscosity, the total loss of the blood of the plasma fluid outside. So the plasma viscosity increases in this part, which leads to more occlusion and more aggregation of the blood cells. Also increased platelet stickiness and aggregation. So this scheme may show the pathophysiology in this order. Capillary changes with the hematological changes leads to the occlusion of the microvasculature, and this leads to the retinal capillary non-perfusion, because the blood and the oxygen carried on this blood cannot pass from this occluded part to the next. So there is part deprivated from the blood vessels, from the blood and oxygen. So the non-perfusion leads to tissue hypoxia. Hypoxia means loss or defected oxygenation of this tissue. Leads to retinal ischemia, and then the retinal ischemia stimulates the release of the VEGF. VEGF is a vascular endothelial growth factor, which is in response to the ischemia and the hypoxia. They are working as an aids, as a helper for the ischemic part to grow, to help the growth of a newer blood vessels to supply the blood and oxygen to that ischemic part. But actually it's an abnormal blood vessels, an abnormal behavior, and finally leads to neovascularization, which is present in the different parts of the retina, also around the optic disc. The part around the optic disc is called the neovascular neovascularization around the disc is called NVD, and NVE means E means elsewhere. Also, the neovascularization in the other parts of the retina, also NVI, which means the neovascularization in the iris, which is the Repusis iridis, which leads to neovascular glaucoma later. So the NVD and the NVE leads to retinal hemorrhage and subhyaloid hemorrhage in the space between the vitreous phase, the posterior vitreous phase, and the retina is called the subhyaloid space. Also inside the vitreous cavity, inside the vitreous gel, it's called the vitreous hemorrhage. So there are different types of the hemorrhage. So there is intraretinal hemorrhage, pre-retinal hemorrhage, subhyaloid hemorrhage, which when gets inside the subhyaloid space, and when gets inside the vitreous gel itself is called the vitreous hemorrhage. About the neovascularization elsewhere, there is a fibrovascular proliferation, which is called the PVR, leads to fibrous glial tissue proliferation. This fibrous tissue is contractible, so it leads to contraction of this fibrovascular membranes, which leads to traction on the retina, leading finally to the traction retinal detachment. And then this traction on the retina leads to retinal tears, which may lead to, at the end, rhegmatogenous retinal detachment. So this patient may have two types of retinal detachment, which is rhegmatogenous retinal detachment and the tractional retinal detachment, which starts first. About the NVA, the NVI leads to NVG, which is the neovascular glaucoma, because there are abuses iridis, which are abnormal blood vessels, grow in the iris, especially in the angle of the anterior chamber, leads to obstruction of the trabecular meshwork, which prevents the drainage of the aqueous humor into the venous circulation, the scleral venous circulation on the outside of the eye. So there is retention of the aqueous humor with intractable increase of the intraocular pressure. So it's called secondary open angle glaucoma at first, when they are just occluding or obstructing the trabecular meshwork, but the angle is still open. But finally, after adhesion and formation of the peripheral anterior synechia, there is secondary angle closure glaucoma. So this glaucoma with long-standing increase of the intraocular pressure, which is usually intractable and does not respond or it is not decreased easily with the treatments, so leads to optic atrophy and absolute glaucoma, absolute eye with a loss of vision. So it is dangerous a process, so we have to know well and control properly. There is the EDEMA. What's the EDEMA? EDEMA, it's the arteriovenous chance. It's a helping secondary response to the ischemia to bypass this occluded and obstructed part of the circulation to form a newer connection between the arterioles and the venules is called the AV chance or the EDEMA. So the EDEMA is one of the signs of the severe form of the non-proliferative diabetic retinopathy, and it's an alarm that this condition is going to be a proliferative disease. So it's one of the signs of the vasoformative changes and substances around the hypoxic retina. Clinical features of the diabetic retinopathy. In this picture on the left side, this is the normal retina. This is the optic disc, normal color, normal vasculature, and also this is the normal macula with the normal distribution of the blood vessels around, and with the less pigmented, or sorry, the less perfused part of the retina, which is more pigmented. This part is called phase, the part of the macula which is mostly a vascular part to enable better vision and detailed vision. So the phase has a normal properties of the normal features to be normal macula. If this phase is increased, means more ischemia. If this part is decreased by attacking of blood vessels, newer vessels, or leakage, this is the abnormal signs which could be present in the diabetic retinopathy, as shown in this figure on the right side. This is the diabetic retinopathy, or the picture of the diabetic retinopathy, with the microaneurysms, edema, and exudate in the central part of the retina. Also, neovascularization around the disc, as you see. This is the NVD, and neovascularization in the peripheral part of the retina up. This is the NVE, and with the cotton wool spots. This cotton wool spots is one of the signs of ischemia. This part is hypoxic and ischemic, so there is no enough vasculature. There is no enough blood vessels, and so this part is changed. As you see, it's whitish in color because it's pale, it's hypoxic or ischemic part. So the clinical features of the diabetic retinopathy includes the microaneurysm. Microaneurysm actually is the earliest sign of the diabetic retinopathy. Appear as tiny red dots. It's focal saccular dilatation of capillary walls where pericytes are absent. Located in the outer plexiform layer, please hands its place. It's located in the outer plexiform layer and the inner nuclear layer, usually at posterior pool, especially temporal to the fovea. So the microaneurysms usually present at the posterior pool, especially temporal to the fovea. In the fundus fluorescein angiography, they are present at the edge of area of capillary non-perfusion, hyperfluorescence dot. This is the sign of it. Retinal hemorrhages, dot and blood hemorrhages. The dot and blood, dot which is a tiny dot, and blood which is a larger point or dot. The two rupture of wall of capillary or microaneurysm, giving rise to intraretinal hemorrhage. If the edge is deep, like in the inner layer of the OPL, outer plexiform layer, it's usually is round or oval. It's usually around or oval, so it's dot or blood hemorrhage. The flame-shaped hemorrhage, it's larger and wider hemorrhage, arise from the superficial precapillary arterioles when it's closer to the inner part of the retina. The hemorrhage is more superficial, so it takes the shape of the arrangement of the nerve fiber layer, so it appears as flame-shaped hemorrhages. It takes a flame splinter shape because they follow the architecture of the nerve fiber layer, as I mentioned now. What about the exudates? There are two types of exudates, the hard exudates and soft exudates. Hard exudates are yellow deposits of lipid, lipoprotein, and lipid-filled macrophages within the outer plexiform layer and the inner nuclear layers. They are arranged in clumps or form circinate pattern around the microaneurysm, frequently at the posterior pole. These are signs of current previous macular edema. As you see in this figure, this is a circinate hard exit. There's yellow deposits of lipid and lipoproteins in the circular fashion and the pattern, so it's called circinate. What about the cotton wool spots? I told you seconds earlier that the cotton wool spots is a sign of ischemia, where there is a hypoxic part. So it's called a soft exit. They are white fluffy lesion in the nerve fiber layer caused by capillary occlusion at the nerve fiber layer due to infarction. Also, one of the clinical features, the intraretinal microvascular abnormality, which is called EDEMA. I mentioned, I described it before in the previous figure about abnormal dilated tortuous retinal capillaries that act as a shunt between the arterioles and the venules. It's within the internal limiting membrane. It's very, very superficial from the inside of the eye in the fundus. What about the venous changes? The venous changes in the diabetic retinopathy could be in the form of beading, looping, and severe segmentation due to venous stagnation because of the increased viscosity and occlusion of the other side of the circulation. So the beading, like in the first, like in the first on the left side, yeah, this is the beading, looping in the middle figure, and severe segmentation in the left, in the right figure. So we may start from the right to the left. The figure on the right, this is segmentation. In the middle is the looping, and on the left side is the beading due to venous stagnation. One of the most important points to know about the diabetic retinopathy is the classification. When I examine the fundus of the patient, I can say from the fundus examination by the naked eye using the slit lamp and auxiliary lenses or the indirect ophthalmoscope, that this patient has a definite or has which stage of the diabetic retinopathy. There are a lot of classifications before, but I will talk about the more recent one by the ETDRS, which is the early treatment diabetic retinopathy study classification. They are classified into the non-proliferative diabetic retinopathy and proliferative diabetic retinopathy, and finally advanced eye disease. The non-proliferative diabetic retinopathy includes the mild, moderate, and severe. The mild, when you find microaneurysm, dot plot retinal hemorrhage, and hard exudates. Moderate, when you have the mild plus cotton wool spots, venous changes, and EDEMA. And the non-proliferative diabetic retinopathy will be severe if you have the previous moderate features, plus one of the coming microaneurysm, retinal hemorrhage in all four quadrants of the retina, or venous changes in 2 or more quadrants, or EDEMA at least in 1 quadrant, which is the 4-2-1 rule. The moderate plus one of the coming in the 4 quadrants, or venous changes in 1, it's not severe. In 2 or more quadrants of the retina or the fundus will be severe, or EDEMA plus the previous one, at least in 1 quadrant of the fundus. Very severe diabetic retinopathy, very severe non-proliferative diabetic retinopathy, 2 or more of the above features on the severe non-proliferative diabetic retinopathy. So before getting the subhyalid hemorrhage or the vitreous hemorrhage or the severe retinal hemorrhage, which is called pre-retinal hemorrhage, you are still in the non-proliferative diabetic retinopathy. There is no PVR, which is the fibrovascular membrane. If you don't have any fibrovascular membranes, you are still in the non-proliferative diabetic retinopathy. The second class is the proliferative diabetic retinopathy. It could be early, mild, non-high risk, or high risk. The high risk, when you have neovessels on the disc, it's called NVDs, more than 1/3 of the optic disc diameter with or without hemorrhage, or less than 1/3 of the optic disc diameter with hemorrhage. It's called pre-retinal hemorrhage and the vitreous hemorrhage. Together with the NVDs, you are at high risk. Or neovessels elsewhere in fundus, NVEs, more than half of the optic disc diameter with or without hemorrhage. Less than half of the optic disc diameter with hemorrhage. Even pre-retinal or vitreous hemorrhage. So if you find these features as either in the NVDs or the NVEs, you will diagnose this patient as a high-risk PDR, proliferative diabetic retinopathy. This clinically significant macular edema is one of the important features to know when you are gonna diagnose or examine the fundus. If you find the clinically significant macular edema before getting or sending this patient for further investigation, you will be worried about this patient because of the macular edema, the macular exudation, and that the vision will be in danger. So the modified Ehrlich-House criteria, they stated that the retinal edema within 500 microns of the central fovea, or hard exudate within 500 microns of fovea centralis associated with adjacent retinal thickening, or retinal edema that is 1 disc diameter or larger, any part of which is within 1 disc diameter of the fovea centralis. Clinically significant macular edema. You know that the macular edema, as I mentioned before, is caused by the exudation and the vascular leakage. So if you remember, I told you that the macula or the fovea is almost a vascular part, so there is no blood vessels. So the exudation could travel a distance to arrive or to reach the fovea or the central part of the macula. So this means that there is a large grade or a long time and large amount of exudation to get in this part. So if you find the retinal edema within 500 microns, which is 0.5 millimeter of the fovea, or fovea as it's pronounced in some authors, or find hard exudate in this part within 500 microns of this part, is also clinically significant macular edema, or may find retinal edema which is 1 disc diameter or larger at any part but 1 disc diameter from the fovea centralis. Present any part away from the fovea, but it's not away, it's not out 1 disc diameter of the fovea centralis. It's an important clinical sign to send this patient for investigation, to investigate by the fundus fluorescein angiography and the OCT to study the need of this patient for interventions. Finally, the management, how to manage the diabetic retinopathy. First of all, you have to take a history, a careful history from this patient. To take a careful history about the behavior of the diabetes, the control, and find out the lab diagnosis or lab history of this patient. Also the clinical features ocular examination, including the best corrective visual acuity, slit lamp examination to examine the cornea, iris, and lens. You will examine the cornea for any changes from the backside, for any changes from the surface, because there is no direct effect from the blood sugar in the cornea, but about the status of the cornea, if there is any epithelial abrasions, if any infections, or any sign of changes of the intraocular pressure. You may find that the cornea, there is epithelial edema, there is stromal edema, which may note you that there is increased intraocular pressure, especially in the patients with uncontrolled diabetes and advanced diabetic eye disease. Also the iris, you will examine the iris, firstly for the behavior, for the appearance of the iris. Also, you will use the higher magnification to detect or exclude the neovascularization of the iris, what's called erbusis iridis or NVI. Also the lens for the vacuolar changes, and the posterior part of the lens, the diabetic patient is more prone to develop vacuolar cataract or the posterior subcapsular cataract earlier than the other people, so examine it carefully. Fundoscopy is a crucial and the very important part of the ocular examination in diabetics, to check the disc and the macula and the retina elsewhere to exclude the presence of the early signs of diabetic retinopathy, non-proliferative. And if you find the signs, you will look for the signs of the proliferative diabetic retinopathy, or the macular, or the clinically significant macular edema. So the visual acuity estimation and in correlation with the blood sugar level is very important, because the patient may come to your clinic with the changes in the visual acuity, but the fundus is normal, the lens is well, the cornea is well too, but if you check for the blood sugar, you'll find there it's not controlled properly. So the fluctuation of the blood sugar level may affect the vision. So control it first before deciding something about the glasses or other means. Investigations. We are usually sending this patient for the laboratory test, blood sugar, the fasting blood sugar, and the random blood sugar, and the postprandial 2 hours after a meal blood sugar. And let me to tell you about the importance of the serum lipid profile in such patients. I'm usually sending the patient for the blood sugar estimation and also lipid profile checking, because the risk of the atherosclerosis and the vascular damage will be higher if the lipid profile is not well. So the medical evaluation of the glycosylated hemoglobin, which is a HbA1c, which gives us information about the status of the blood sugar level within the last 3 months. So it's very important in the follow-up of these diabetic patients. Ancillary tests like the color fundus photography, fundus fluorescein angiography, which gives us the map, the vascular map of the eye, the arterial circulation and the venous circulation, capillary circulation, the presence of the microaneurysm, the presence of the leaking points, and the fundus. So it's very helpful. So the OCT, which is the ocular coherent tomography, gives us a section in the retinal layer to show all layers of the retina, if there is a macular edema, if there is a clinically significant macular edema, sorry, the OCT is called optical coherent tomography of the retina. OCT is an abbreviation for this investigation, with optical coherent tomography. So that it's very important to decide the thickening or thinning or the presence of cystic edema or the other changes, the presence of the hard exudate, also the presence of the PVRs, if there is retinal membranes. It's very, very important and helpful tool for diagnosis and to judge the need of this patient for intervention for the diabetic retinopathy. Finally, how to treat. If you diagnosed well, so you have to know how to treat this patient. The treatments or treatment modalities are a lot. So maybe after medical treatment, the first line is proper and strict control by the internist. Also, the medical treatment for the predisposing and risk factors, like if you have an abnormal lipid profile, adjusting the triglycerides, cholesterol, and the lipid map profile. Also, the blood pressure should be considered. If it is abnormal or there's hypertension, should be controlled properly. Also, if there's other hormonal problem in this body, should be addressed. The treatment should be addressed. The same, I prefer to start with a supporting medical treatment for the microcirculation, dilators for the microvasculature, also for the neurovitamins and tonics to support the nerve fiber layer and the retinal layers. I may add the non-steroidal anti-inflammatory drugs like the ibifenac or nibifenac or the other substances like it to support the decreasing the macular edema. So the medical treatment first, and then I may go for the surgical interference like laser treatment. Laser treatment using the argon laser. Argon laser photocoagulation of the retina to help decreasing the leakage by coagulation and the cauterization like effect of the leaking points of the retina to decrease the vascular leakage and to help absorption of the macular edema and improvement in the vision. You may start in the simple and minor cases with a focal laser around the leaking points, but avoid the macular area. You have to avoid giving laser or shooting laser in the macular area to avoid injury of the fovea. Grid laser, focal laser elsewhere, but the grid laser, it'd be like the inverted C later around the macula, around the fovea, between the upper arc and lower arcades of the blood vessels. So the band retinal photocoagulation, which is called the PRP in the advanced cases with neovascularization and the proliferation, you will coagulate all over the retina, the posterior pole and the anterior part or the peripheral part of the retina to dump the neovascularization and prevent the leakage, prevent the hemorrhages and the formation of the PVR. The second line of treatment is the intravitreal injection or the intravitreal injection. There are two types, but the commonly used today is the anti-VEGF injections. These substances is injected directly into the vitreous through a point 4 millimeter in the phakic, 4 millimeter from the limbus in the phakic eye, and 3.5 millimeter from the limbus in the pseudophakic or aphakic eyes. To enter this needle through the pars plana part of the eye, to get in the vitreous, to then inject these substances, which will travel to the posterior part of the retina and absorbed by the retina to block the VEGF, the vascular endothelial growth factor. This substance will bind with these substances and receptors to prevent the formation of neovascularization, and also it has an effect on the macular edema, help decreasing. This effect helps decreasing the macular edema and improvement of vision, as well as control of the diabetic retinopathy changes. The laser indication. Grid and the focal laser with the clinical, in case of clinically significant macular edema. PRP is considered in the PDR in the high risk and the early proliferative diabetic retinopathy. The focal laser burns only microaneurysms and leaking points. Grid laser around the edema except the foveolar avascular zone, FAZ. The PRP, it burns the viable retina, which is suffering from ischemia, to prevent the formation of the neovessels. As it burns the ischemic retina, so reduces the VEGF secretion and by the ischemic retina. Anti-VEGF, it's a humanized monoclonal antibody fragment. Anti-VEGF binds with the VEGF, neutralization of VEGF, so VEGF can't bind to receptor. So there is no neovascularization. It reduces vascular permeability, inhibits leakage, and also control the formation of neuron 1. Anti-VEGF commonly used is the bevacizumab, which is called Avastin trade name. The dose 1.25 milligram, and the amount is 0.1 milliliter to be injected inside the vitreous. Ranibizumab, which is the Licence, the dose is 0.5 milligram. Indications: the non-proliferative diabetic retinopathy with a clinically significant macular edema where you cannot manage with a laser photocoagulation. You can inject these substances. To control this part. Also helps the control of the blood vessel, neovessel formation elsewhere. PDR with clinically significant macular edema, armed with CNVM, which is armed means that the age-related macular degeneration, especially the wet type with the choroidal neovascularization membrane. Also CMA, which is cystoid macular edema, and CSCR, which is central serous retinopathy, choroidal retinopathy. It's one type, but it's not our subject today. Also the neovascular glaucoma, which is caused by the neovascularization in the blood vessels and the angle of the eye. Also the macular edema, ischemia, and the neovascularization in cases of the central retinal vein occlusion and the branch retinal vein occlusion. The complication, there is scleral complications at the site of the injection, also cataract formation by touching of the back of the lens, glaucoma by increasing of the vitreous pressure and in turn the intraocular pressure, the vitreous hemorrhage by injury of part of the cerebral body or part of the retina, if you were not in the proper position and direction. Also the endophthalmites, and it's the most dangerous complication is endophthalmites by advancing a microaneurysm inside the eye with a contaminated material. So it's very risky because you may lose the eye itself. Retinal detachment also by entering the eye away or beyond the PRP, the pars plana. If you are not, if you didn't inject 4 millimeter from the limbus, you may accidentally enter from a wrong position 5 millimeter from the limbus. You will perforate the retina, and leads to retinal detachment. So it's very simple procedure, but at the same time it carries along a lot of complications. So finally, after all these complicated slides about the diabetic retinopathy, I think it's an interesting subject because it's very important and very common in all eye clinics. So we may conclude at the end that the diabetic retinopathy is the diabetic mellitus is a chronic metabolic disease which has a vascular changes affecting the microcirculation. So it has a crucial impact on the vital organs such eyes, kidneys, as well as nervous system. Diabetic retinopathy is a preventable disease if managed properly. Regular follow-up is mandatory 6 monthly by fundus examination together with a laboratory investigation, especially the HbA1c, to detect any early changes. The early management, the better outcome, and the vision-saving opportunities. Every other day, there is a new revolution in treatment modalities, but we should respect the considerable staging of each modality according to evidence-based protocols. And thank you very much.